It is my pleasure to introduce you to Dr. Stephen G. Wegensbach that will cover the management of thyroid papillary cancer in pediatrics, looking at the past, present, and touching on future avenues to address this condition. Dr. Wagensbach is a medical doctor with an appointment as a professor in the Department of Endocrine, Neoplasia, and Hormonal Disorders at the University of Texas MD Anderson Cancer Center in Houston, Texas. This is a joint appointment with the Department of Pediatrics Patient Care. Dr. Wagensbach was uniquely trained in both adult and pediatric endocrinology at the Indiana University Medical Center in Indianapolis, and he maintains board certification in both pediatrics and adult endocrinology. Since 2002, he has been in his current position and is consistently recognized as one of the American's top doctors for cancer in endocrinology. Having a broad scope practice, Dr. Wagensbach major clinical and research interests are thyroid cancer, hereditary endocrine tumor syndromes, and pituitary tumors. He served as a member of the American Thyroid Association Task Force that revised the medullary thyroid cancer guidelines in 2015 and was a co-chair of the inaugural 2015 guidelines for pediatric thyroid nodules and differentiated thyroid cancer. Currently, is co-chairing the task force revising these pediatric guidelines. Considered to be an expert in thyroid cancer and other endocrine tumors, Dr. Wagensbach feels that he is privileged to be able to take care for patients with these diseases across the age spectrum. Now, we, the members of the Latin American Pediatric Endocrine Society, are privileged to welcome Dr. Wagensbach. Dr. Wagensbach, welcome. The floor is yours.
Well, thank you very much for your kind invitation to present at the SLEP workshop this October. So again, appreciate the opportunity to speak to you and wish we could meet in person, but hopefully at some point in the future. I do have a financial disclosure with Bayer that I would like to show you for this presentation. What I plan to do over the next 45 minutes is specifically focus on pediatric papillary thyroid carcinoma, explain how we've managed it in the past, and that includes the context of some current guidelines that are being revised. I'd like to share with you how we think about management in the current era since the inaugural ATA guidelines, and how we think about surgery and giving radioactive iodine for these patients. And finally, I'd like to show you a glimpse into the future as where we might be a few years from now as we incorporate knowledge regarding the molecular mechanisms of thyroid cancer into treatment algorithms. As you are well aware, there are many differences in papillary thyroid carcinoma between children and adults. Of course, papillary thyroid carcinoma is the predominant type of thyroid cancer that occurs at any age group. But specifically in children, we're really talking about papillary carcinoma in almost all cases. We see rare cases of either poorly differentiated or anaplastic carcinoma in children. Children have larger tumors, they have more invasive tumors, they also have a higher rate of lymph node and lung metastases compared with adults. And the molecular mechanisms of thyroid cancer in children is quite different as well. So children with papillary cancer tend to have somatic fusions, typically involving the genes RET or NTRK1 or NTRK3, whereas adults tend to have more of a point mutation in the BRAF V600E. Because of these differences in molecular alterations, we tend to see more disease that is iodine avid and iodine responsive in children compared with adults where we see less iodine avid disease. And because of all of this, children, even in the presence of distant metastases, have an excellent long-term prognosis as relates to papillary carcinoma. Just to remind everyone that thyroid cancer, and again, we're focusing on papillary thyroid carcinoma, basically results from a single normal thyrocyte, a thyroid follicular cell, that acquires either a mutation in BRAF-RAS or a fusion in these genes or other genes that aren't listed here. And that's what drives the development of papillary carcinoma. As I mentioned earlier, fusions are predominant in pediatric PTC, and I just wanted to spend a little time talking about this in more detail. So as I try to explain it to patients, fusion is basically when you have two genes that shouldn't have any relationship. And due to a chromosomal rearrangement, those two genes get placed next to each other and form a fusion protein. So as you can see here, the green and the orange genes should not have any relationship. They're on different chromosomes, but when they get placed next to each other, they create a fusion that creates a gene fusion protein that then activates signaling and leads to tumorigenesis. Now, in PTC, the predominant fusion we see is a fusion involving the gene RET, the same gene that we see in multiple endocrine neoplasia type 2. Second most common are fusions involving either NTRK1 or NTRK3. Less common are fusions involving ALK or BRAF. And then the Pax8-PPAR gamma fusion can be seen in follicular variants of papillary carcinoma, but we tend to think of this occurring more often in follicular thyroid carcinoma. A recent study from Korea basically looked at the fusion prevalence based on age, and you can see here that children less than age 10 almost always have a fusion involving RET or NTRK1 or 3. As a child gets older, you start to see more of the BRAF V600E point mutations. When I talk about fusions or point mutations, I'm alluding to somatic mutations. Those are molecular events that occur only in the cancer itself. But when we see a child with papillary cancer or any type of thyroid neoplasia, we should also keep in mind that there are hereditary causes of differentiated thyroid carcinoma as well. The two main ones to remember are the P10 hamartoma tumor syndrome, also known in the past as Cowden's syndrome or other eponyms. And then the Dicer-1 syndrome is another one that's associated with differentiated thyroid carcinoma. So a clue to these is, of course, a family history of multinodular goiter or other cancers that are associated with these syndromes. But also, I think it's important to always, when we see a child with nodular thyroid disease, to measure their head circumference, because at least in P10, almost all children with a P10 mutation will have macrocephaly, and about 40% will in the Dicer-1 syndrome. So that's an important little clue that perhaps this child has an underlying hereditary cause of their differentiated thyroid carcinoma. I'm sure the group is very familiar with the diagnosis of papillary carcinoma, but just wanted to remind everyone that the best way to diagnose thyroid cancer is doing a fine needle aspiration under ultrasound guidance. In the past, I remember when I was a fellow, the teaching was any child with a thyroid nodule should go straight to surgery, and that's how they get their diagnosis or not. But really, no child should go to surgery now without a preoperative ultrasound-guided FNA. So that is the most critical way to making the diagnosis. So there are still challenges, though, even in the current era. We see patients like this. This is actually a fairly benign-looking thyroid nodule that turned out to be a papillary carcinoma, and I copied this from the surgeon's note that basically said that FNA is usually not helpful in children. And so going straight to thyroidectomy is appropriate. So this happens even today. But really, fine needle aspiration biopsy is really critical because, one, you want to know, okay, it's a malignant diagnosis that may change the flavor of surgery that's going to be performed. And then it also lets you pause and think, okay, did I really interrogate those lateral neck lymph nodes very well to look for evidence of lymph node disease? Here's another patient. We still see patients who get excisional biopsies. So they actually go to surgery to, have a lymph node excised. And, unfortunately, that does make the diagnosis, but we would prefer not to have yet another episode of anesthesia for that child. So again, these are just some examples of what's still happening today, but really our children who are suspected to have papillary carcinoma should have a biopsy. I mentioned earlier that children have a higher rate of lymph node and distantly metastatic disease. So obviously this is an extreme example, but a lot of children who clinically present with papillary carcinoma will have lateral neck disease. And in some series, even up to 80% of children with papillary carcinoma have lymph node disease. Lung metastases occurs in 10 to 25% of children, and it just depends on the series. So if you look at a cancer center like mine, we'll see up to 25% of our patients have lung metastases. But the reality is probably more on the 10 to 15%. The risk of lung metastases is actually quite higher in children who present like this with these bulky cervical lymph node disease. So that's one clinical clue that can make you more suspicious that that child may have lung mets. We do see bone and solid organ metastases in pediatric thyroid cancer, although fortunately these are rare cases. And also brain metastases are quite rare in papillary carcinoma in childhood. One thing to keep in mind about the clinical presentation is that PTC can sometimes be difficult to diagnose because it doesn't necessarily present as a discrete nodule in the thyroid, and it may present with a concomitant autoimmune thyroid disease. So it's not uncommon to see children who have more diffusely infiltrative papillary carcinomas that involves either the whole thyroid lobe or can involve even the whole thyroid gland. So here on the left, you can see this is an adolescent patient. She was diagnosed with Graves' disease, actually. And you can really appreciate there's not much even of a goiter that can be seen there. But on ultrasound, she had evidence of a diffusely infiltrative papillary carcinoma. And the clinical clue to this was the fact that she had palpable lymph nodes. This is a patient here that was diagnosed and treated for Hashimoto thyroiditis and hypothyroidism. But you can see she had an asymmetric gland, which can happen, but in addition, she had palpable lymph nodes. So here are two examples of children with autoimmune thyroid disease that actually had underlying locally metastatic papillary carcinoma. I'd like to spend just one slide talking about long-term outcomes and survival because it's important to understand that the prognosis is excellent. And this is something we should be telling our parents at the beginning, that their child's going to do very well, even if they present with distantly metastatic disease. And because we know children do so well, it also helps us understand how aggressive or not we should be in treating that child, particularly when they're very young. This on the left is from a study using a SEER database, which is a large cancer database here in the United States. And basically, overall disease-specific survival was 99% at 30 years. So what that means is at 30 years after diagnosis, only 1% of pediatric papillary carcinoma patients died of their cancer. And of course, the worst outcomes were those with distantly metastatic disease that are represented here in this light gray. But even then, at 30 years out, you can see that the survival is 94%. So excellent long-term survival. If it's not distantly metastatic, you can see that the disease-specific survival is, like I mentioned here, about 99%. On the right is actually a study from MD Anderson that we recently published, and this is specifically looking at patients diagnosed during childhood with papillary cancer or follicular cancer who were found ultimately to have lung metastases. And our study agreed with that of the SEER database in that our disease-specific survival at 30 years was 93%, and the median disease-specific survival was over 5 decades. So even if a child presents with very advanced disease, they're still going to do well in the vast majority of cases. And so that's an important take-home message to share with our patients and their families, and also for us to take to heart as we determine how aggressive or not we're going to be in treating that patient with radioactive iodine and surgery. Let's now move on to the treatment of thyroid cancer. And we can all appreciate how it's not just the endocrinologists who help to take care of these children. It really is a group effort. It takes a village, so to speak. And so very important to have an organized multidisciplinary team who takes care of these patients. I've mentioned these guidelines. These were the first guidelines really ever published specifically in a comprehensive fashion to look at the management of pediatric thyroid nodules and pediatric thyroid cancer. This was sponsored by the ATA, but co-sponsored by the Pediatric Endocrine Society. And I should say that it was endorsed by the Latin American Thyroid Society as well. These came out in 2015, and I kind of view those as the past now because, you know, our practice has evolved even over the last 6 years, and these guidelines are currently undergoing a second or an initial revision. So the best way to cure thyroid cancer is to find the right surgeon to remove the cancer. And so surgery is really the mainstay of how we treat our patients. And important to find an experienced thyroid cancer surgeon. It used to be that we treated every child with papillary cancer with radioactive iodine, even if they had just a speck of thyroid cancer. Now that's not a given, and we currently use additional data, the pathology, the postoperative staging, to determine if iodine will be of benefit. So it's not will treat with iodine, it's may treat with iodine. Finally, we use exogenous levothyroxine to suppress the TSH, and we'll monitor long-term with thyroglobulin and imaging studies. Again, I can't emphasize enough how important it is for these children to be treated at high-volume centers, particularly the youngest children presenting with very advanced disease. Those patients usually have significant cervical disease burden, and they're really at high risk for permanent hypoparathyroidism and recurrent laryngeal nerve injury. Once you've made the diagnosis of PTC with a biopsy, it's important to do some additional kind of preoperative evaluation. Of course, if you haven't already done a comprehensive neck ultrasound, you want to make sure that you have an ultrasound that interrogates the lateral necks, particularly to look for any lymph node disease, and you would like to biopsy those if feasible and prove it preoperatively. I will do a chest x-ray sometimes, but I've actually moved away from this, that I don't do this as often. I do, once the diagnosis is established, check a thyroglobulin antibody. I find that helpful, not because it helps you determine treatment, but you can already know which patients have thyroglobulin antibodies and kind of start that discussion of how that may complicate the follow-up and how we will monitor that. And finally, what's most important for surgical planning is to actually get good cross-sectional imaging. We tend to favor CT neck, possibly with chest, in those patients presenting like that patient I showed you with the bulky lymph node disease, because those are the patients that are going to be at the highest surgical risk and also the highest risk for lung metastases. The preoperative ultrasound is very important. Here's a good example. This is a 6-year-old who actually has a diffusely infiltrating papillary cancer. You can see here how there is no discrete nodule. This is the right lobe. It clearly is larger, so this is where the tumor originated. Here's the isthmus, and here's the left lobe of the thyroid. And you can see there are microcalcifications throughout. This patient actually had palpable lymph node disease, so you're not surprised to see these abnormal lymph nodes on ultrasound. But sometimes we don't palpate. And a lot of times, actually, it's hard to palpate these lymph nodes. And so that's where ultrasound is so important for looking for evidence of lateral neck disease, because it will change your initial surgical management. I mentioned before that CT scans are what we use here, and most institutions will use. Although you can use an MRI, we find that CT offers much better spatial resolution, and it's much easier on the patient. So in someone with bulky disease, here's a patient with a very large primary tumor. Again, this is another example of a diffusely infiltrative tumor without a discrete nodule, but very important to look at where all the disease is. And in this case, as is typical for a lot of young people, you can see that there's a lot of lymph node, a lot of lymphadenopathy posterior to the thyroid. So the thyroid's here, and here are all these lymph nodes that are socked into the central compartment. These are lymph nodes you can't appreciate via ultrasound. The ultrasound just can't get past the thyroid to see this. Sometimes it can, but a lot of times you may miss this. So this is very vital to have this information so that the surgeon knows, wow, there's a lot of disease here. This is going to be an all-day case, and I'm going to have to microdissect out the recurrent laryngeal nerves and be very deliberate in looking for the parathyroid glands. A lot of people are worried about getting CT scans because of the contrast, but I want to reassure you that it's okay. And a CT neck should always be given with contrast because it's otherwise not helpful. You need to give the contrast. And the contrast really doesn't delay the ability to give radioactive iodine very much. And children tend to clear that iodine load very, very quickly. And again, even if radioactive iodine is delayed by 3 to 6 months, that is okay because again, I've shown you how well these patients do this. So it's not an emergency to give radioactive iodine. So I want to encourage everyone who meets a patient with bulky neck disease to make sure there is good preoperative imaging. I know everyone is very familiar with thyroglobulin as a tumor marker that we use for differentiated thyroid carcinoma. I've mentioned I usually measure it once the diagnosis is established, and it's important to always use the same lab so we can compare apples with apples. Children with thyroid cancer, and specifically really children with papillary thyroid carcinoma only, and those with lymph node metastasis, there's about a 40% chance that child will have thyroglobulin autoantibodies. Of course, if antibodies are present, you can't interpret thyroglobulin levels in most of the commercial assays used today. And in that setting, what we do is follow the antibody levels themselves. And we would expect that the antibody levels will clear within a few years after surgery in someone who does not have persistent disease. Now, there are older radioimmunoassays that some people will use to monitor thyroglobulin. I personally don't do that because I think following the antibody titers is usually sufficient. And then there's also been some question about testing thyroglobulin via mass spectroscopy. And that also is not the solution that we had hoped it would be because there are patients who have structural disease who may still have a negative thyroglobulin as detected via mass spec. Of course, thyroglobulin responds to the TSH level. And so, a stimulated thyroglobulin level is the most sensitive way to look for evidence of persistent or recurrent disease, but sometimes can still be a false positive. And now we have these ultra-sensitive thyroglobulin assays where the lower limit of detection is down to like 0.1 nanograms per ml. And so that has almost taken the place of doing stimulated thyroglobulin values because you can detect, low levels of thyroglobulin with these sensitive assays. So a lot of us have moved away from thinking of getting stimulated TG levels in these patients. Another important caveat to remember about thyroglobulin is that it may continue to decline years after radioactive iodine. So just because a patient has detectable thyroglobulin 1 or 2 years after their first dose of radioactive iodine doesn't mean that may not continue to improve over time. So that's not always a trigger to treat with more iodine. And we still don't know the thresholds at which we should be treating children with PTC. In adults, we tend to think of a stimulated value of greater than 2 to be suggestive of residual disease, but we don't have similar good data in children. Although there are some studies that would suggest a stimulated value greater than 10 is more suggestive of disease. Going back to surgical therapy, again, most children will benefit from total thyroidectomy. And I say that because a child who presents with clinical disease often will have lymph node disease associated with it. A lateral neck dissection should be done if you have biopsy-proven disease in the lateral necks. And if you do a lateral neck dissection, you should also, or the surgeon should also do a central neck dissection. Or intraoperatively, if they identify central neck disease, they should do a central neck dissection. What has been very controversial is the role of prophylactic central neck dissection, meaning you do the neck dissection even without evidence of disease. Most of us don't recommend that, at least to do a bilateral central neck dissection because the risks likely outweigh the benefits, but can certainly selectively be considered based on the experience of the surgeon. A lot of times what we'll do to compromise is we'll do an ipsilateral central neck dissection on the same side as the primary tumor. And that kind of strikes the right balance sometimes in terms of risk and benefit. Now there's accumulating data that total thyroidectomy may not be needed in all children with thyroid cancer. And again, it used to be any child with papillary cancer would get a total thyroidectomy, particularly because of the risk of multifocality and because everyone was given radioactive iodine. But now there are patients that we can identify who might benefit just from a hemithyroidectomy or a thyroid lobectomy and isthmusectomy, as seen here in the blue. And here are just two studies, one from Toronto and the second one from Philadelphia, that have looked at this and have made recommendations for what children might benefit from less comprehensive surgery and do okay with that. Who should perform surgery? Well, there's older studies that show that children tend to have higher complication rates, and that when thyroid or parathyroid surgery is done by a high volume surgeon who does a lot of thyroid and parathyroid surgery, that length of stay is lower and overall outcomes appear to be better. So this led the ATA guidelines in 2015 to suggest that surgeons should be doing at least 30 or more cervical procedures a year to be considered a high volume surgeon. This has, of course, been debated, but we still, I personally still feel it's very critical for any child with thyroid cancer to be operated on by a surgeon who does that. And it may not be the pediatric surgeon. It may be more of an adult surgeon, endocrine surgeon, or an adult head and neck cancer surgeon. And the reason why this is so critical is we want to try to avoid cases like this. This is a patient who had outside surgery. You can see had bulky lymph node disease, but her scar is consistent only with a thyroidectomy. She did not have this, and she had actually been given radioactive iodine as well, and presents to us with this bulky residual disease. Her left vocal cord was paralyzed, and she had residual disease on the right near the right recurrent laryngeal nerve. So this is why it's so critical to find the right surgeon at the beginning. The 2015 guidelines brought up this initial concept of risk categories and basically taken or adapted from the adult guidelines, to be honest. But this was our first step to say that there are low risk pediatric patients that do not need radioactive iodine routinely after surgery. So this was kind of a first step towards that direction. And in those patients with low risk as defined here, the initial staging may just be checking the thyroglobulin. And if that's undetectable, then no radioactive iodine will be needed and that patient can be monitored. Most children will still be intermediate or high risk patients, and therefore most children will still proceed forward with a diagnostic scan and possible treatment. Now, there are other societal guidelines that actually recommend that all children with papillary cancer should get treated. Here are guidelines from Poland, and these are some recent guidelines from the Netherlands, where they recommend routine treatment, except perhaps those with a microcarcinoma. I apologize if I've missed any guidelines from Latin America that relate to pediatric thyroid cancer, but I just wanted to show that there are still differences in opinion across the world. Why do we use radioactive iodine? Well, it's clear that we use it in a therapeutic form to treat patients who have known iodine-avid disease, like this patient here on the left with lung metastases. We no longer routinely give radioactive iodine to everyone for routine remnant ablation. And that's because we now know that, after surgery with a high volume surgeon, that thyroglobulin is very informative. We don't need to give radioactive iodine to destroy remnant thyroid tissue. What's harder to know is the adjuvant therapy category, where we give radioactive iodine to kill off any residual microscopic disease. And so, we still have, I think, to learn who are the patients who would more clearly benefit from adjuvant therapy versus those where we may not need adjuvant therapy, even if they had lymph node disease. This is my personal approach to how I manage children after a thyroidectomy. I do believe it should be a personalized approach where you do postoperative restaging with radioactive iodine and then determine if the child would benefit from treatment or not. So of course, your intermediate or high-risk patients will wind up getting a stimulated diagnostic whole body scan, and the guidelines have firmly recommended getting a diagnostic scan in all cases, and we'll discuss why. There's a lot of value in it. And so we don't recommend treatment just with a post-treatment scan. I think it's important to get that diagnostic scan, and critical to also see what that thyroglobulin is, if it's interpretable at the time of the scan to help make treatment decisions. And I know this is in reality very difficult to achieve. Sometimes, I'm blessed I worked at a center where we run our thyroglobulins in-house with a quick turnaround time. But it can be very challenging when you have to do the labs at an outside lab and you may not have the thyroglobulin available at the time you need to make these critical decisions. But in this idealized situation, you might have a patient like on the left where there's no uptake and there is no thyroglobulin that is, or a significant thyroglobulin level. So these are patients we can actually avoid giving iodine to, even if they had lateral neck disease at the beginning. Here are the patients where we know we should treat, right? This is a patient with lung metastasis, maybe also a lymph node metastasis here. So, that becomes clearer. And the diagnostic scan may actually upstage the patient. This may be a patient you weren't aware had lung metastases. And so seeing that on the diagnostic scan can help you choose a more appropriate dose. On the right-hand side, you might see a patient like this, where the diagnostic scan shows uptake in bilateral lateral cervical nodes, no uptake in the lungs. This is a patient where actually we should stop and not give iodine to and reevaluate this patient for surgery. And of course, this is the more challenging situation here where you have a single focus of thyroid bed uptake with a minimally stimulated thyroglobulin. So this is the adjuvant therapy setting. Will this patient benefit from routine iodine? Yes or no? We still need to better study that. Iodine dosing is typically given in an empiric fashion. You can certainly do dosimetry, but that is very expensive, time consuming. And so most centers use empiric dosing. This is not very scientifically based, but basically it depends on what your goal is. You're trying to treat soft tissue metastases, bone metastasis, or you're just doing it more for remnant ablation in the adjuvant setting. So we basically adapt or adjust the dose based upon a typical dose we would give an adult patient for the same indication. SPECT-CT imaging is also very important, and we've really adopted this in most patients over the last 10 years or so. And this is so helpful to try to identify where the uptake is. So here's a patient that you can see this planar image, and the SPECT-CT helps us better understand that, this uptake here is actually not cancer. This is ectopic thyroid tissue at the level of the hyoid. But yes, there is uptake here, and this is actually a supraclavicular lymph node that was missed with surgery. And then, you can see here, this patient had lung metastasis, and you can localize it to the lungs. Now, radioactive iodine can certainly treat iodine avid disease in the neck, but we still prefer surgery to cure the neck of disease. And, here's a patient I met about a year ago or so who had been treated with this residual bulky lymph node disease in the neck. And you can see she had excellent uptake. This is actually the diagnostic scan, not even the post-treatment scan. And after 28 months, the tumor has shrunk, but it's still there. And you can see it still enhances. So really, radioactive iodine should not be used to try to cure cervical disease unless it is small volume cervical disease. Also important to recognize that children with thyroid cancer may not always have iodine avid disease. Here's a patient with an intrac fusion who had gotten another dose of radioactive iodine, very intense uptake. You can see here in the lungs, but here's another patient diagnosed at age 14, wasn't recognized to have lung metastases until age 23 and had no uptake in the lung metastasis, even with the same fusion that this patient had. So we're still learning a lot about how the genotype correlates with the phenotype of radioactive iodine avidity. Certainly, iodine is safe in most patients, but there are side effects that we need to be aware of. Inflammation of the salivary glands, sialadenitis can occur. Children tend to have more nausea and vomiting. And then, of course, the late effects are ones that give me a little bit more pause as I'm treating a child with advanced thyroid cancer. Again, keeping in mind their long-term prognosis is excellent, no matter what we do sometimes during childhood. But things I worry about are pulmonary fibrosis and late second malignancies, and there is data to suggest that the radioactive iodine therapy may increase the risk of leukemias and salivary gland tumors. Pulmonary fibrosis is something to consider in patients like this, where they have diffuse miliary disease and they have diffuse uptake in the bilateral lungs. These are the patients you really don't want to be so aggressive on, as this is an example of a patient who was treated quite aggressively with radioactive iodine. I saw her because she had become short of breath and there was a concern for disease progression. But over that time interval, her thyroglobulin had actually improved. And unfortunately, she had developed pulmonary fibrosis. We also now have better data to say that children with lung metastases are actually rarely cured with multiple doses of radioactive iodine. So these are various series. Most of these are more recent. If you look at some older data from Europe, they saw a complete response in 45% of children with lung metastases. But in the current era, this is our experience here on the right. We only had 7% who completely responded. And this is a Japanese study. I think this is from Canada. This is from Saudi Arabia. So you can see that, the vast majority of patients actually don't get a complete response. So that's also very important to keep in mind as we treat children with radioactive iodine. And these are the challenges we see in clinic. I think treating a child with lung metastasis is very challenging. You've seen this scan before, but here's a patient that we gave a dose of iodine to, but still had persistent biochemical disease. And so how often do we actually give it? Do we give it every year? Do we give it just as needed? So we're still learning that. I can tell you in my practice, I will give a single dose and hold tight. And if I see evidence of something changing, then I will give a second dose at that time. And the other question is, well, how many doses? Is there a ceiling? Is there a maximum that we can give these children? So here's a patient with, lung metastasis, after dose 3 here at age 8, still a lot of uptake. So when would we actually give dose 4? And do we give dose 4? And now that we have better data to say that we cure a few patients with radioactive iodine, I actually, would say that no, we shouldn't give any more iodine and save it for the future. So the bottom line is using radioactive iodine in pediatric papillary carcinoma, particularly for lung metastasis, is that slow and steady wins the race. We really should take more of the approach of the tortoise and not the hare. After radioactive iodine, of course, we will suppress the TSH depending on the risk of the patient, and then we'll monitor that patient. This is an algorithm published in the guidelines that are now considered the past. Still very important to use neck ultrasound, primarily along with thyroglobulin or thyroglobulin antibody assessment to follow these patients. And there may still be a role for doing follow-up diagnostic whole body scans, but I can tell you in my own practice, I don't do this anymore. The only time I will do a diagnostic scan is if I am intending to give that patient a second dose of iodine. But regardless, these guidelines are very clear in saying that you should only use repeated courses of radioactive iodine in children who have proven or suspected iodine avid disease and who also demonstrated prior response. So this is a very important step to take in moving forward to not treating children as aggressively. Some caveats about as children as they grow up. It is important to follow these patients and to have a transition to an adult thyroid cancer specialist when the time is appropriate. Here's a patient who had been diagnosed at age 9, was followed here regularly, but then was lost to follow-up until she presented with symptomatic disease. She had a painful jaw lesion. She had a lesion in her calvarium and was actually coughing up blood. So very important to really encourage our patients to have that ongoing follow-up. We also need tincture of time to identify lung metastases. Particularly in tumors like BRAF mutated tumors that don't concentrate radioactive iodine. But as I've shown you, we also see that in fusion positive tumors. So you might see a patient that might have a few scattered nodules in the lungs that could just be a sequela of prior lung infection. But it may take years or even decades before you recognize that, oh yeah, these are lung metastases. So again, very important to have that plan for transition for our pediatric patients into adult medicine. I'd like to now focus a little bit more on the management of advanced disease and the future of how care may look like. This represents the evolution of how we treat advanced thyroid cancer. Since the 1930s, when thyroid hormone was first used to suppress the TSH. And we now have this huge number of drugs that have been studied and approved to treat thyroid cancer. And there's now still ongoing studies in the use of immune therapy. How do we use more precision medicine with targeted therapies? Trying to get tumors to redifferentiate or take up iodine, or a combination of these various therapies. But in the beginning, and what we still use predominantly in children, it's TSH suppressive therapy. And this is the original report by a surgeon in England who identified that these patients, who actually were pediatric thyroid cancer patients, that their cervical disease shrank after they were given thyroid extract. And as typical for pediatric thyroid cancer, they were both alive and well 22 years later. So TSH suppression is still the front line for treating advanced disease. And often we will just monitor the disease while continuing the TSH suppressive therapy. Now, there are some patients who may require systemic therapies. This is looking at our experience with stage 2 disease, meaning lung metastases. And as would be expected, the majority of these tumors had actionable fusions, minority had BRAF mutations. We can contrast that with adults. So these are patients around age 60 with lung metastases or other distant metastases. We see these are more BRAF predominant tumors, followed by fusions. And then we also tend to see more RAS mutated tumors. But a lot of these molecular alterations now have targeted therapies available, and we don't have time to go through this, but this is a list of all the therapies that are out there, and we are now accumulating more experience in treating children with these therapies. A very exciting area that's gaining traction, and we're doing a lot more investigations of, it's this concept of redifferentiation therapy, and it actually started with using MEK inhibitors or BRAF inhibitors in BRAF mutated tumors in order to kind of trick the tumor to take up the radioactive iodine again. But now we're getting evidence too that the selective NTRK and RET inhibitors, again, these are much more critical for the pediatric population, may also do the same. This is a recently published case of a child with iodine non-avid disease in the lungs who was treated with a selective RET inhibitor. And as you can see here, had reintroduction of iodine uptake into the lungs. So a very exciting area of research. So our old hammer for treating thyroid cancer, particularly advanced thyroid cancers, using radioactive iodine and repeated courses of it. But now we have all these new drugs that selectively inhibit the molecular alterations in these tumors. And so I think we're moving from the current paradigm where we do surgery, radioactive iodine, they give repeated courses of radioactive iodine, and eventually introduce kinase inhibitor therapy for patients who have failed iodine. We're entering this new era where we're thinking of things differently. So we might now use kinase inhibitor therapy even before surgery. And we're participating, we have a study now looking at that for RET fused thyroid cancers and RET mutated thyroid cancers, that maybe using this therapy before surgery may improve the surgical outcome. And is KI therapy maybe indicated earlier on before radioactive iodine therapy? So it's a very exciting time where I think our treatment paradigms are changing. In summary, hopefully I've shown you that papillary carcinoma in children presents with more advanced disease compared with adults, but is really overall less aggressive. And that's likely due to the underlying molecular differences and other factors. To improve long-term outcome of our pediatric patients with PTC, and also to protect them from over-aggressive treatment, really, these patients should be seen at high volume centers that have established multidisciplinary teams to care for these patients. TSH suppressions and radioactive iodine still remain our frontline therapies for metastatic papillary carcinoma. But as I've shown you, we're moving away from giving repeated courses of high doses of radioactive iodine because it is most likely that patients will still have persistent disease despite that approach, and for lung metastases, I should say. And finally, oncogenic fusions involving RET and INTRAC1 and INTRAC3 are quite prevalent in pediatric thyroid carcinoma. And now we have these new targeted therapies that are starting to change the treatment paradigm. So again, I thank you so much for inviting me to participate in this SLEP workshop, and I'll be happy to take any questions.
Thank you very much for this wonderful presentation. And now the floor is open for questions. Please let us know what you would like to ask, and it will be Dr. Wagensbach's pleasure, I hope, to answer your questions.
Bueno, ¿qué tal todos? Bienvenidos, gracias por haber presenciado la presentación. Aparentemente hemos tenido problemas técnicos y Steve no se ha podido comunicar, así que estamos a la espera de su presencia. Yo recibí algunas de las preguntas que fueron enviadas y lamentablemente, dada mi falta de conocimiento en el tema al nivel necesario, creo que no estoy en condiciones de poder contestar las mismas, solamente especular. Simplemente diría que realmente la presentación fue muy interesante. Yo no había tenido acceso a los slides, pero nos llevó en el camino de cómo ha evolucionado el tratamiento y el abordaje de esta condición, y también ha mostrado con claridad los nuevos descubrimientos en cuanto a la presencia de factores genéticos y la diferencia entre los mismos a la edad de presentación y cómo estos dan cuenta de la posibilidad de abordaje. También me parece muy importante cómo él insistió en el uso de las técnicas diagnósticas, no solamente de tratar de identificar a los tumores usando la citología, pero también previo a la cirugía el uso de la tomografía computada contrastada u otro tipo de cosas que permitirían identificar ganglios que la sonografía no permite. Lamentablemente, hacia el final de la charla, aunque él mencionó el uso de estas nuevas drogas y los grandes descubrimientos en los últimos 10 años en la utilización de las mismas, el uso de estas medicaciones en chicos no ha sido tan amplia como en adultos, así que no sabemos muy bien, y dado también el buen pronóstico, entre comillas, que tiene esta enfermedad en esta población, la evaluación del riesgo-beneficio, dado de las múltiples complicaciones endocrinas y no endocrinas que estas medicaciones tienen, no está claro realmente cómo su utilización debería ser, digamos, más frecuentemente considerada de lo que es en la actividad, y que quizás los casos más difíciles de manejar sean plausibles de recibir esta medicación. Finalmente, creo que también fue muy interesante su acento en el rol del yodo y la necesidad a veces o la posibilidad de esperar en la intervención de este tipo, porque esto no es una urgencia médica, y también en ser cautelosos en el uso de este abordaje en el paso del tiempo, ya que, como él mostró el ejemplo de la tortuga y la liebre, un abordaje un poco más menos agresivo y se hacía más eficiente y efectivo que un abordaje más agresivo. Veo acá una pregunta y lo que me dicen es que Steven no se ha podido comunicar. Así que una vez más les pido disculpas por el problema técnico, más aún les pido disculpas por no conocer el tema de manera profunda como para evacuar las preguntas muy interesantes que ustedes han hecho, y me despido de ustedes hasta la próxima. Chau, chau.